Many BCBAs are responsible for making clinical recommendations for treatment hours, decisions that shape families' daily lives. But the reality is, most of us were trained to deliver ABA, not to decide how much of it someone actually needs. There's no clear formula, no standardized process for making this determination. So we estimate, we compare to what others are recommending. We go with what's worked in the past. And sometimes, maybe even most of the time, we're guessing. Add in real world pressures such as agencies that won't accept clients unless the family agrees to 20, 30, or even more hours per week. Directors who push for more hours in the plans, insurance companies that approve hours but make it nearly impossible to increase hours if needed. In that environment, it's easy to fall into the routine of just recommending 30 hours because it's safest. But the question we should be asking isn't how many hours, it's what are those hours actually for? And who are they serving? If you've wrestled with that question, you're in the right place. For those of you who don't know me yet, I'm Amelia Delphonse. I'm a BCBA and I co-founded Master ABA with my twin sister, Diana Kelly. Through Master ABA, we help BCBAs gain confidence in their skills so they can have a greater impact with their learners. Our focus is on ethical, compassionate, learner-centered practices. This course is eligible for CEUs. You must watch the video all the way to the end. There will be a short quiz for you to take once you finish the video. You must pass the quiz in order to receive your CEU certificate. There will be a link after you pass the quiz to a brief survey. I appreciate your feedback because this helps me improve the courses that I'm offering. If for some reason you miss a step or have any trouble with your certificate, feel free to email me at support@masteraba.com. I'm happy to help you with anything that you need. This course is designed to help you navigate one specific challenge: how to determine the right amount of ABA services, especially when systems around you are built on rigid, outdated models. Here's what you'll walk away with: a clearer understanding of what the research actually says about ABA dosage, a practical, flexible framework for making individualized dosage recommendations, strategies for using parent training to reduce the need for high-intensity direct services, and tools to help you respond when insurance reduces hours or won't authorize more, and a stronger ethical and clinical rationale for the decisions you make about treatment hours. You're not going to get a magic formula, but you will get a process, one that you can justify with data, explain to funders, and feel confident standing behind. Let me tell you a story that still frustrates me when I think about it. My cat was having problems with his mouth. Literally the day we were leaving for our vacation, and he was already at my daughter's house. She called me to tell me that his mouth was bleeding and she was going to take him to the vet. The vet said he needed to see a specialist. My daughter called the specialist that our vet recommended, and that vet told her the cat needed surgery with a price tag of $6,000. $6,000. She called me and we tried to figure it out. Do we dip into our savings? Do we apply for the care credit card that the vet recommended, even though we don't believe in carrying credit card debt? Do we delay it and hope it doesn't get worse? If we can't afford it, if we don't make these sacrifices, are we neglecting him? Eventually, my daughter called the original vet back and said, "We can't afford the surgery. Is there anything else we can try?" She paused and said, "Well, we could try an antibiotic. It might help, but it could be an aggressive form of mouth cancer that's not treatable." This gave me pause because this was the first mention of something that might not be treatable. They wanted us to pay for a $6,000 surgery on my cat who's 14 years old when that might not actually fix what's wrong with him. We picked up the antibiotics. It cost $20. Within a week, he was fine. He was eating fine. He was purring. He had no signs of pain. That experience stuck with me because we were about to jump into the most intrusive, expensive option without trying anything less invasive first. And I realized that we do this with ABA too. We recommend high intensity services first. We assume that more is better. We skip right to the $6,000 solution without even asking if the $20 antibiotic might work. That's what this course is about, taking a step back, rethinking how we make those decisions. Take a moment to think about one of your own cases. When you recommended a number of treatment hours, what influenced that decision? Was it the assessment data, expectations from your agency, what you thought insurance would approve, or maybe you just did what you always do for the kids with similar profiles? Let me tell you about a family that I worked with. Their son was 2 years old, and they had already been to 2 different ABA clinics. Both of them told the parents that he would need to be there for 30 hours or more a week. The parents couldn't imagine what that would look like. He was so little, and they didn't want him to spend that much time away from home. The parents were divorced, but had a really solid co-parenting relationship. Dad stayed home full time to care for him, and mom worked from home. They were very hands-on and wanted to be an important part of his life. When I met them, they were exploring home-based services. During the assessment, we had a conversation, not just about the assessment data, but about what they were realistically comfortable with. I ended up recommending 20 hours of RBT time plus 1 hour per week of parent training. And I'll be honest, in the past, I probably would have recommended 30 hours without thinking twice. It was the standard that I had used for a kid with his profile. But in this case, it didn't feel right to push that. That moment shifted something for me. So think about your own practice. When have you adjusted a recommendation to better match a family's needs or values? Or when have you wanted to, but didn't feel like you could? So let's take a step back for a minute and talk about what's become the default in our field. You're not imagining it. Most recommendations that I see, both in practice and on social media, fall somewhere in the 25 to 40-hour range. That's the standard, the assumption, and the starting point. And more, I'm seeing companies require families to commit to a minimum number of hours just to access services, especially for home-based providers and small businesses. Now, I want to be clear, there are some really practical reasons behind this. Staffing is a huge challenge. It's hard to find and retain good technicians when they're only getting 6 or 8 hours a week on a case. Scheduling becomes a nightmare, and it's hard to build an efficient schedule when the RBT is only seeing a client for a few hours a week. I get that. For smaller providers, especially, there's a real need to maintain some operational stability. But here's the thing. What started as a logistical workaround has in many cases become the clinical standard. Families walk in the door and are told, you have to agree to 25 hours or we just can't take your case. And that changes the conversation from what does this child need to what fits the model that we've already built. So if you felt like you're stuck recommending more hours than you think are necessary, or if you've seen families turned away because they couldn't commit to a certain number of hours, you're not alone. This is what the system is currently set up to expect, but that doesn't mean that it can't change. This is why we're here. This course isn't about throwing shade at high intensity programs or pretending low intensity is always better. It's about stepping back and asking, how do we make this decision on purpose? How do we stop letting logistics, assumptions, and system pressure dictate what we recommend and start reclaiming clinical judgment? because we all want to do what's right for the learner, but we're operating in a system that often pushes us toward what's easiest to authorize, what's easier to staff, or what's already in the treatment plan template. This course is about making room for a different approach, one that centers the individual, one that includes the family, and one that uses the research, not just our routine. We need to move away from dosage as default and toward dosage as a thoughtful, individualized, and ethical decision. And we need to make sure it's something that we can sustain, not just for the client, but for the system, the staff, and ourselves. Let's go back to 1987. That's the year Ivar Lovaas published what's probably the most famous study in our field, his intensive early intervention study. That paper included 38 autistic children with 19 placed in the intensive treatment group. That group received about 40 hours per week of discrete trial training, mostly in a one-to-one setting for 2 to 3 years. The other children received around 10 hours per week. The kids in the intensive group had significantly better outcomes across several domains, including IQ scores and what the study called mainstreaming outcomes. The study became the foundation for insurance coverage of ABA, and that's 40 hours per week was framed as what's medically necessary, and that number has stuck through the years. But here's what often gets lost. That was a small sample, a single model, a very specific set of procedures and criteria, and yet it's become our benchmark for recommending service dosage. After Lovaas published his findings in 1987, that 40-hour model didn't just stay in the research journals, it became the foundation for insurance policy. In the early 2000s, as states started passing autism insurance mandates, insurance companies were under pressure to define what counted as medically necessary ABA, and they needed to create something quickly. There wasn't a standardized dosage tool. There weren't dozens of long-term replication studies to draw from, but there was the Lovaas study. And so bit by bit, policy writers pulled from that one study to define intensity guidelines. Some policies even included direct references to 25 to 40 hours per week for young autistic children as the expected standard. This didn't just influence coverage, it shaped the entire field. Because once insurers started approving 30 plus hours per week, providers learned to write plans that matched what would be reimbursed. Over time, that model wasn't just common, it became expected. By 2019, all 50 US states had passed autism insurance mandates, and most of those policies had similar language because many just reused or adapted existing definitions from earlier states or private payers. So now we had this feedback loop. Insurers approved 30 plus hours, agencies wrote plans around that, systems were built to deliver it, and new BCBAs were trained into that structure. This is how reimbursement logic quietly became clinical logic. Many of us were trained to believe that high intensity ABA was what's best practice, when really it was just what was most billable. So when BCBAs today feel stuck recommending 30 plus hours, even when it doesn't feel quite right, it's not a personal failing, it's the system that you inherited. And it's time that we start talking about that. It's also worth looking at what that original intervention actually involved. The 40 hours Lovaas delivered weren't spread across multiple settings or service models. It was clinic-based, highly structured, and used almost exclusively discrete trial training. There was limited parent involvement. Generalization wasn't a major focus. It was a very different kind of ABA than what most of us are delivering today, especially in home-based or naturalistic settings. So if we're still using that study to justify 30 to 40 hours per week of modern ABA, we need to ask, is the model even comparable to what we're delivering? Are we actually replicating the conditions in that study? And if we're not, what exactly are we basing the dosage on? So let's fast forward to 2024. Sandbank et al. Published a massive meta-analysis looking at over 150 studies on early intervention for autistic children, including many ABA-based programs. So here's the big takeaway from that article. There was no consistent relationship between the number of hours a child received and their outcomes. In other words, more hours didn't consistently lead to better results. What did seem to matter more was duration. The kids who were in intervention programs for a longer span of time across months or years tended to see more progress, but the weekly dosage varied widely without any clear pattern. This should make you pause because it means the more is better logic that we've leaned on for decades doesn't really hold up as well as we thought it did. So what does this mean for us in practice? First, we need to stop assuming that more hours automatically means better outcomes. That belief has been drilled into us, but the evidence just doesn't really back it up. Second, we need to look at what happens during those hours, not just how many there are. If the client is fatigued, if the technician is burned out, if the family can't carry it through, then those hours lose value very fast. So what really drives progress? And that's consistency over time. Interventions that fit the client and the family, opportunities for meaningful generalization, and yes, treatment integrity and client engagement. Now, before we swing the pendulum too far, let's be clear. This research doesn't prove that low-dose services are better. It also doesn't say that high-intensity services never work. What it does say is that outcomes don't consistently map onto hours. So we have to stop prescribing based on an arbitrary number and start planning based on the need, the context, and the response of the client. This is a call for nuance, for individualized clinical reasoning, for pulling back from default dosage and moving toward clinical purpose. And that's what we're going to focus on in the next section. So let's talk about another study that really helps clarify what we just saw in the Sandbank meta-analysis. Lindstedt et al. 2017 looked at a large data set of children receiving early intensive behavioral intervention. They wanted to understand what mattered more, intensity, or the number of hours per week, or duration, which is how long the child had been receiving services overall. What they found was pretty eye-opening. Duration was the stronger predictor of improvement, especially in communication, social, and adaptive domains. In other words, children who stayed in services for a longer span of time tended to show more progress, even if they didn't receive the highest number of weekly hours. Meanwhile, weekly intensity, getting 30, 35, or even 40 hours per week, had a much smaller and less consistent impact across the data set. So this reinforces the idea we just talked about. It's not just how much intervention we're delivering in a week. It's how consistently that support is sustained over time. So what do we do with all of this? It means we might want to start thinking about how to stretch the arc of services instead of trying to pack as much as possible into each week. If we know that long-term support drives progress, then our goal should be to create a model that families can actually stick with and that insurance companies will approve over a longer period of time. Because what often happens now is that we start high, we recommend 30 plus hours per week. Families burn out, staff turnover increases, and insurance looks for you to titrate hours and may deny plans when services persist at high intensity for too long. Instead, what if we built plans with sustainability in mind? What's a reasonable starting point given the family's current capacity? How do we preserve staff engagement and treatment integrity over a longer period of time? And can we deliver fewer hours per week, but make them more focused, more supported, and longer lasting? This isn't about lowering the quality of service. It's about protecting it by making sure the model is strong enough to last. So far, we've talked about how the research doesn't consistently support high intensity services, but there's another layer here, and it's about what actually happens in the real world. Just because a plan is approved for 30 hours a week doesn't mean 30 hours are actually being delivered. Think about the cases you've had where a tech calls out, the family goes on vacation, or the child gets sick. Staff leave, and it takes weeks to train someone new. When you zoom out and look at what was authorized versus what was actually utilized, it's often a very different story. We might write a plan for 35 hours a week, but if they're really getting 22 hours on average, then our dosage in theory is very different from the dosage in practice. This matters because it impacts outcomes, treatment fidelity, and even how families and insurance companies perceive the effectiveness of ABA. And if the real world model can't consistently deliver 30 to 40 hours, maybe the solution isn't trying harder to hit that number. Maybe the solution is designing a model that anticipates fluctuation and still works. When we go looking for research on treatment dosage, many of us already have a preferred conclusion. We want to find the studies that back up what we believe, or maybe even what we need to believe to keep our systems running. We want to defend our recommendations to the insurance companies. We tell ourselves, I recommend 30 to 40 hours because that's what the research says is best. But often we're selectively reading that research. We hold on to one or two studies that support high intensity services, including the Lovaas study, and we ignore others that say something different. That's called confirmation bias. And here's the harder part. Recommending high hours often makes our lives easier. It keeps caseloads smaller. It's easier to staff full-time RBTs, and there's less paperwork per hour delivered. It avoids uncomfortable conversations with supervisors or funders. So when we see research papers that support high-intensity services, we grab onto it, not just because of science, but because it protects the structure that we've already built. This isn't about blame. It's more about awareness. If we want to make ethical, individualized decisions, we have to check our own assumptions and be honest about the incentives that we've built into our systems. So let's pause here for a second. You've been listening to me talk through my own lens, your own background, your own clinical experience, your own beliefs. Maybe when you saw the title of this course, you thought I was going to say we should go above 30 hours, that our kids and families deserve even more intensive intervention. Or maybe you thought I'd say that 30 hours isn't enough unless we also add 10 hours of parent training, that we're falling short. Or maybe you expected me to argue that 30 hours is too much, that we need to cut everything down and push for minimal services. Whatever your initial thought was, I want you to stop and just notice it. What did you expect to hear from me? And more importantly, what assumptions were underneath that expectation? Because we all come to this with biases. Sometimes we believe that more is inherently better because it feels safer. Sometimes we think less is unethical because we're afraid of doing too little. Sometimes we believe that families if families really cared, they'd want as many hours as possible. But what if those assumptions aren't actually true? Take a moment. What beliefs are you bringing into this conversation? And we'll build from there. So let's talk about the shift that we're here to make. What would happen if we paused, and I mean really paused, before we wrote a dosage recommendation, before we dropped in 30 hours, because that's what this profile usually gets, before we copied the plan from a similar client, or before we assumed that more hours equals better outcomes? Instead of going straight to what's expected, what if we started with curiosity? What does this family actually want? What's their capacity? Not just logistically, but emotionally. What are we hoping those hours will achieve? And can fewer hours delivered with greater focus and intention get us there? This is about shifting from defending our defaults to questioning our defaults. Because here's the thing, the science is evolving, the systems are changing, and the only way to stay ethical, responsive, and sustainable is by asking better questions before we start writing our plans. We're not here to push less or push more, we're here to think. So let's talk about low dose models, because yes, they exist, and yes, they can work. In the research, we see growing evidence that some learners can make meaningful gains with lower weekly service hours, especially when those hours are well targeted, supported, and sustainable over time. These aren't low quality cases, they're just structured differently. Instead of stretching RBTs to deliver 35 hours of direct service with variable fidelity, these models focus on higher treatment integrity, focused targets, better parent engagement, and plans the family can actually follow through on. These aren't underserving, they're adjusting for the context of the family. And for some learners, less hours delivered well can go further than more hours delivered inconsistently. Another promising model is parent-partnered intervention. And this is different than just tacking on a weekly hour of parent training. This is where the parent is the central implementer, with the BCBA and RBT in a coaching or support role. We're not just trying to train parents, we're building their capacity to integrate behavior analytic strategies into everyday routines. Think about the long-term value of this. Strategies get used across time and settings. Generalization happens naturally, and parents become confident, active participants, not just passive recipients of care. This isn't new. Studies have shown that parent-implemented interventions can be effective for language development, social skills, and adaptive behavior, sometimes with just a few hours per week of direct clinical contact. These models don't replace all in high-intensity care, but they absolutely expand what's possible. So let me give you a few examples from the research. Rothstein et al. 2021 showed that learners receiving lower weekly service hours but with strong family engagement made comparable gains in communication to those receiving more intensive services. Brookman, Frazee et al. 2009 studied naturalistic developmental behavioral interventions, or NDBIs, implemented by parents with coaching, and showed real improvements in child social communication skills. And then Simon, 2005, used pivotal response training paired with parent coaching and found measurable gains in communication and behavior without relying on full-time direct service. These studies highlight a critical shift. It's not about how much intervention we deliver, it's about how embedded, accessible, and meaningful it is in the child's real life. So let me share a case that stayed with me. I had a family reach out for services for their 2-year-old son, and their insurance didn't cover ABA. They were going to pay out of pocket, and they wanted help figuring out how much that was going to cost them. And I'll be honest, my whole mindset shifted then. I didn't start with how many RBT hours can I justify? I started with what's the most efficient, impactful use of this family's resources. We talked about goals, values, availability, and what they were hoping to see change for their son. And I recommended parent training as the central focus, not as an add-on, as the primary intervention. And in fact, we didn't introduce an RBT for over a year because it didn't make sense to charge this family $100 an hour or more for direct service when I knew I could make more progress by working with them directly and helping them embed support throughout the day. Now, here's the question I want us all to sit with. Why do we think differently when the money comes from insurance? Why is it easier to recommend 30 hours of direct service when the family isn't the ones writing the check, but harder when they are? Because here's the truth. It's still someone's money. It's still the family's time, and it's still the learner's experience. We say we want efficient, ethical, sustainable care, but sometimes our default shifts when a funding source is less visible. So let's stop and ask, would I recommend this model if the family were paying out of pocket? If the answer is yes, then maybe it's worth considering for all families. How would your treatment plan change if the family was paying in cash? Even when we want to be thoughtful and individualized with our dosage decisions, we're still going to counter barriers. Insurance is a big one. Many plans require you to justify every single hour. And if you don't ask for enough upfront, it's nearly impossible to increase the hours later. That creates a lot of pressure to recommend more hours at the beginning, just in case, even when you suspect it's more than the family can realistically manage. As we talked about earlier, agencies often impose minimum hour requirements to help with staffing and scheduling. Especially in home-based services, it's hard to find a tech for just 6 or 8 hours a week. So companies implement policies like we only take clients committing to 20 plus hours, which turns a business need into a clinical default. And then there are logistical challenges. RBTs who call out, families who are canceling sessions, long onboarding timelines for new hires. All of that leads to service gaps and burnout, even in high hour plans. These are real obstacles. This isn't about blaming providers. It's about naming the system that we're working inside of. This brings us to the heart of the ethical tension. On paper, our job is to recommend the number of hours that's clinically necessary. But in practice, we're often also asking, what will the insurance approve? What will the director sign off on? What can I staff? What's the safest number to put in the plan? It's no wonder so many BCBAs feel stuck, even when you want to recommend fewer hours because it aligns better with the learner's needs or the family's life. You know that going below a certain threshold might lead to denial from insurance, get pushback from your agency, make the case harder to staff, or put you in conflict with company leadership. And all of that puts you in a bind. Do you protect your clinical integrity, or do you protect the family's access to care? That's why this conversation is so important. We're not just talking about hours. We're talking about autonomy, ethics, and the long-term sustainability of our field. We've talked about why less isn't always less, but here's the real takeaway. Efficient, individualized models don't just benefit the learner, they benefit everyone involved. Families are more likely to stick with services when those services fit into their lives. They don't feel like they're choosing between their child's care and their own well-being. Often families don't even feel like they can take a vacation with their child because they might miss out on services. RBTs and BCBAs are more likely to stay engaged and deliver high quality services when they aren't spread too thin. When we choose our models carefully, we make room for treatment integrity and staff retention. Agencies benefit from lower turnover, less retraining, and more stable scheduling. And those insurance companies are looking for value. When we can show that we're using resources effectively, delivering meaningful progress without overprescribing, we become better partners. That protects access for everyone. So this isn't just an ethical shift, it's a strategic one. Efficient models protect the system by helping it last. So let's take a look at the clear framework for making treatment dosage decisions. Begin by collecting relevant information and using a structured scoring system to estimate intensity needs. From there, consider caregiver capacity. What's realistic? What's sustainable? And who's available to support the work? Once we've done that, we can make a well-informed, individualized recommendation that starts with what's minimally necessary to be effective. But we don't stop there. Build in regular review of fidelity and learner progress, and stay flexible about the number of hours that you're recommending. And finally, when you're ready to communicate with funders, do so from a place of clarity, ethics, and evidence, not just by your default. So let's talk about how to make decisions about treatment intensity. We're trained to assess behavior, but when it comes to recommending hours, we often lean on what we've seen before or what others in our agency are recommending. The first step in this framework is about moving away from assumptions and toward structured clinical reasoning. We gather information about the learner, the environment, the family, and we make a data-informed estimate of how intensive services might need to be. This doesn't mean that we're using a rigid formula or jumping to a predetermined number. It means that we're considering key variables like communication, safety concerns, learner readiness, and the support that's available, and how likely this learner is to respond to intervention at different intensities. The goal here is to generate a starting point, not a final answer. And from that starting point, we find a recommendation that fits the learner, the family, and the real world that they're all living in. Right now, we don't have a standardized, universally acceptable tool for determining ABA treatment intensity. Research on POP-C, the Patient Outcome Planning Calculator, was published in 2023, and it shows a lot of promise. It's a 33-item tool that helps categorize clients into low, medium, or high intensity tiers based on things like behavior severity, communication, and environmental needs. But here's the catch. You can't download it, and it's still in beta, so you can't actually access it. The authors are seeking feedback and data. So while it's great that we're moving in this direction, we don't currently have access to a tool that will help us actually calculate treatment dosage today. I think Central Reach or one of the other data collection platforms had developed something, but I can't seem to find it. If you know of an available tool, please let me know about it. So what do we use in the meantime? One tool I often recommend is the Aetna Medical Necessity Guide. It includes a dosage estimation table based on functional impairment in areas like self-care, communication, and maladaptive behavior. It's not perfect, but it gives you a structured starting point instead of just guessing. That being said, it doesn't account for some really important variables such as safety concerns, especially with things like elopement or self-injury, family capacity, environmental stability or unpredictability, and parent availability or their stress. These things matter, and they directly affect what dosage is going to be effective, not just what sounds good on paper. So in the absence of a perfect tool, we take what's available and supplement with sound clinical judgment. In the next few slides, I'm going to show you how I combine tools like this with structured observation and parent interviews to build a practical, individualized starting point for services. So I created the Clear scorecard. It's something that I made specifically for this course. It's not a research validated tool. It hasn't gone through peer review. It's not meant to be a replacement for formal assessments or standard guidelines. What it is, though, is a structured way to organize your clinical thinking. It's built on the best research that's currently available, insights from my own practice, and the kinds of constraints that we all face in the real world. The goal of the Clear scorecard is to help you move away from vague estimates or inherited defaults and toward a more intentional process for thinking about dosage. It walks you through 5 domains: behavior, communication, adaptive skills, family capacity, and environmental support. It helps you map those to a starting point for treatment hours. But it's not perfect. But it is a tool you can use right now with transparency and in service of more ethical and individualized care. If you do use it, don't reference it in your treatment plans. Like I said, this is just a tool that I used that I'm sharing with you. In the next few slides, we're going to walk through the tool itself, and then we'll apply it to our 3 case examples: Cam, Maya, and Leo. So Cam is 4 years old and was referred to ABA due to an absence of spoken language and frequent intense tantrums. His parents also noted recent aggression towards siblings, challenges with toilet training, and he isn't currently enrolled in school or preschool. Cam lives in a two-home household. His parents are divorced, but co-parent very effectively. His dad, Maxwell, is home with him during the day, and his mom, Susan, works from home. They're both actively involved in his care and are motivated to support him. We're going to use Cam as our first case example as we walk through the Clear framework. And as we go, think about how these kinds of real-world details can shape our dosage recommendations, especially when we move away from a default number toward a more individualized plan. So here's step 1 for Cam's profile. You can start by using the Clear scorecard to organize what you know about Cam. Remember, this isn't a formula. It's a structure to help you think critically about the full picture before jumping in with a number. Let's look at these 5 areas. Challenging behavior. Cam has frequent tantrums and recent aggression towards siblings. These behaviors are disruptive and emotionally taxing for the family. I'd likely score this as a 3 in intensity. For communication, Cam has no spoken communication and isn't using functional communication reliably. That's a significant need, especially at age 4. Likely, we would score him as a 3. And then adaptive skills. He's not toilet trained and isn't attending school. Daily functioning is impacted. So again, I'd give him a 3 in this area. Then we have family capacity. This is where it gets interesting. Both parents are engaged. Maxwell stays home during the day and Susan works from home. They co-parent well and are motivated. I'd score this capacity as a 0 because they're a strength, not a barrier. Environmental support. Cam isn't in preschool or structured care, so there's no educational team providing reinforcement or shared goals. He has grandparents and aunts and uncles who are around, but don't take on significant caregiving responsibilities. I'd rate this as a 2 for the family support, but his family doesn't have any other environmental supports. Now, based on this overall profile, we can see that Cam's needs are high, but family capacity and environmental supports are important assets. His clear score comes out to 11, which places them in the high intensity range of 20 to 30 hours per week. Okay, so here's Leo. Leo is a 12-year-old referred for services due to challenges with independence, task refusal, and limited social engagement. He avoids peer interactions and often shuts down when demands are placed. He's receiving school-based support, and while he does have some moderate needs in daily life skills, there are no safety concerns. What stands out in Leo's case is the strong caregiver capacity. Like Cam, his parents are engaged, consistent, and willing to implement strategies at home. That matters because when families are prepared and able to help carry out interventions, we can often scale back direct service hours without compromising outcomes. As we move into applying the framework, we're going to use Leo's profile to explore how this case compares to Cam's. So start by gathering relevant information, not just about behavior, but about Leo's environment, his support network, and his learning readiness. Leo is 12 years old and attends school part-time. He struggles with hygiene routines, task initiation, and often shuts down when presented with non-preferred demands. There are no safety concerns, and his parents are highly engaged and eager to implement routines. He's also receiving school-based support. When we input this into the scorecard, we see a profile that reflects moderate impairment in daily functioning, no significant safety risks, strong family capacity, and a supportive environment. His clear score comes out to 4, which places him in the low range, which is up to 10 hours per week. And here's Maya. Maya is a 6-year-old recently diagnosed with autism. She engages in frequent aggression and self-injury, and her communication is limited to gestures and sounds. Her parents both work full-time, are overwhelmed, and are seeking immediate support to manage crisis behaviors at home. Maya's total clear score is 13, which places her in the high range of recommended intensity. Recommended starting dosage would fall between 20 to 30 hours per week of direct service, plus frequent caregiver training. This recommendation reflects both high clinical need and limited external and familial support. High-intensity services should be coupled with ongoing collaboration and advocacy to reduce caregiver stress and increase environmental supports over time. We now have a range of hours to consider for each of these examples, but we can't request a range of hours, so we need the rest of the framework to get to our final recommendation. The next step is about caregiver capacity, not just in terms of stress or availability, but as a crucial clinical variable. In the CLEAR framework, this step is about more than scoring family engagement. It's about leveraging the caregivers as powerful agents of change and making service decisions that respect their time, values, and their bandwidth. This might mean adjusting direct service hours downward when a caregiver can implement things effectively, prioritizing parent coaching in the early phase to empower parents, or collaborating with families to determine realistic expectations of their involvement. When we talk about leveraging caregiver capacity, we're not just measuring stress or availability, although those are important factors. We're asking, how can we design a model that taps into what this family does well? If a caregiver is highly engaged and coachable, we may not need 25 hours of direct services. We might get more from 15 hours of focused work plus strong parent implementation. This step is about using the family's real-life strengths to get better outcomes with fewer clinical hours without sacrificing quality or progress. It also helps families feel empowered, not dependent, and that has lasting impact long after our services end. Studies consistently show that when caregivers are trained and supported, outcomes improve, sometimes even more than with increased direct service hours. We see better generalization, better long-term maintenance, and often faster progress. On the flip side, high caregiver stress can be linked to reduced fidelity and less consistent follow-through. That means even great treatment plans can fall flat if the family is overwhelmed. So part of our job is not just to assess caregiver capacity once, but to monitor it over time and adjust our model accordingly. One tool that I've found incredibly helpful is the Parent Stress Scale by Berry and Jones. It's a quick 18-item questionnaire that captures both the burden and reward of parenting. I've included it in your materials and it's free to use. I have permission from one of the authors to go ahead and share it in this course. You can give it to families at intake to help assess stress as part of caregiver capacity. Then you can repeat it after a few months of parent training to see if what you're doing is actually helping them feel more confident and less overwhelmed. It's a simple but powerful way to treat families as part of the clinical equation, not just the child. So let's look at what step 2 looks like for Cam. We know from his case that both parents are highly involved. Even though they're divorced, they co-parent well. Dad doesn't work and cares for Cam during the day, and mom works from home. That gives us availability and consistency, which are both major assets. They've already sought out services, asked questions, and shown a willingness to adjust their schedules to support Cam's learning. That tells me that they're probably coachable. So you administered the parent stress scale and noted a score of 25. The scale ranges from a possible 18 to 90. So this family is on the lower end of the possible scores. They are experiencing some stress, but overall don't feel significantly impacted by Cam's behavior or diagnosis. In this case, I wouldn't just recommend direct hours. I'd want to lean in weekly to parent coaching with both parents, not just as an add-on, but as a central part of the treatment model. With Cam, that might mean reducing direct RBT hours slightly and investing that time into coaching the parents on things like responding to tantrums, supporting communication, and handling transitions at home. This is how we leverage capacity, not just measure it. All right, so let's look at what this looks like for Leo. His parents are clearly engaged, they're consistent with routines, open to collaboration, and eager to support his independence. That tells us that they're likely to follow through with strategies and coaching. You also consider caregiver stress using the parent stress scale. Their score was around 32, which suggests some degree of stress, likely tied to Leo's shutdowns and resistance with non-preferred tasks, but not at a level that would limit their capacity to participate in treatment. Given that, you wouldn't just lean on direct support. This is another family that we can partner with. A lower intensity model with targeted parent coaching could be very effective, focusing on things like building flexibility, promoting independence with daily routines, and increasing his tolerance for demands. This is another case where leveraging capacity means getting more out of fewer hours while setting the family up for long-term success. All right, so let's look at what this looks like for Maya. Her family is under a lot of stress. She was recently diagnosed. Her behaviors include aggression and self-injury, and both parents work full-time. They reported feeling overwhelmed and are seeking urgent support to manage daily routines and safety concerns. If you use the parent stress scale and estimate a score of 63, which indicates a high level of parenting stress. This suggests that follow-through with coaching may be challenging, at least in the short term. This doesn't mean that you abandon parent training, but in this case, you may need to lead with more intensive direct support to stabilize things at home. Over time, as stress decreases and safety improves, you can gradually shift toward a more balanced model that includes stronger caregiver involvement. In this case, leveraging capacity means recognizing where capacity is low and adjusting the model to meet the family where they are without judgment. and with a long-term plan in mind. So step 3 isn't just about selecting a number of hours. It's about designing supports that are effective, but no more intensive than they need to be. So you're asking, what's the least intrusive way to deliver care that still meets the child's needs and supports meaningful progress? So this step calls for clinical creativity. Could this be a front-loaded model where you're providing more hours early on and you have a clear plan to fade those hours over time? Could a consultative approach empower caregivers and school teams instead of defaulting to high direct care hours? You also have to zoom out. Are you preserving a child's time, dignity, and relationships? Are you making space for school, play, and family, not just therapy? A higher clear score might suggest a higher intensity, but that doesn't mean that we automatically go to 30 or 40 hours a week. Instead, we translate that score into a clinical hypothesis. This learner may need moderate to high support right now, but let's explore how to deliver that in the way that's most efficient and family-centered. Step 3 pushes us to ask how little we can do to achieve just enough change without compromising quality. So let's look at 2 ways we might deliver effective services without overprescribing. The first way is to front load. This approach uses higher intensity early on when skill acquisition or behavior reduction may require close clinical oversight. You provide intensive direct services at first, maybe 20 or 30 hours a week, but you plan on fading right from the start. As goals are met and the family builds fluency, you can gradually shift towards the hours towards caregiver training and implementation. This model can be ideal when there are safety concerns that we need to stabilize. The family has strong capacity and can maintain gains, and we're targeting high impact time sensitive goals. The second model is the consultative model. Here we provide lower weekly hours, maybe 10 to 20 hours, but those hours focus heavily on coaching caregivers or collaborating with educators. Direct work is less of a focus, and the client and the direct services are more short term, often just enough to model strategies, assess learning, and refine the plan. This approach works well when the learner has moderate needs, but strong natural supports. The family or school team are eager to lead implementation. We're building skills that can be taught in daily routines. Both models prioritize outcomes over hours and reduce the footprint of intervention on the child's life. There are likely cases that will come to you that truly require high intensity services that we have been recommending all along, but what I'm encouraging you to do is pause and consider if all cases that come to you require this level of intensity. This step is about finding the most efficient path to meaningful change, not the most intensive one. So let's see what this looks like for Cam. His clear score was 11, which puts him in the high intensity range of 20 to 30 hours per week plus parent training. That tells us his needs are significant. He's not yet using spoken language. He's not toilet trained, and he's engaging in aggression toward his siblings. But here's the nuance. Cam's parents are highly involved and consistent. Dad stays home during the day and is actively engaged. Mom works from home and collaborates closely. They've already shown a strong capacity for follow-through and are motivated to participate in learning. So even though the score points us toward a higher total service hours, this doesn't mean he needs the higher end of the range with 30 hours of RBT time by default. Instead, ask, what's the most efficient way to meet these needs without overprescribing? In Cam's case, that might look like 25 hours of direct support to address safety and skill acquisition, plus 1 to 2 hours per week of parent coaching as a core treatment element, not just as an afterthought. Build in a fade plan right from the very beginning, aligned to measurable progress. The intensity is justified, but we're still being intentional, keeping coaching central and looking for natural opportunities to shift toward support towards the family as they gain confidence. This is how we can balance clinical need with real world efficiency by asking, what's the lightest effective version of this plan? So let's see what this looks like for Leo. Leo is the 12-year-old. He has solid communication skills, but he engages in some oppositional behaviors and struggles with following instructions and completing tasks independently. He has that support from school, and his mom works outside the home, but his grandmother helps with after-school care. Leo's clear score was 4, putting him in the low to moderate intensity range. So we're not looking at high behavioral risk or significant skill deficits, but he still needs support, especially around independence, routines, and follow through. So here are the least intrusive recommendations. Here's what that might look like. And it might take the form of a consultation model. And it might be 5 to 10 hours per week of direct service with a strong focus on collaborating with school staff and family caregivers, plus weekly caregiver coaching, helping grandmother and mom use consistent strategies across home routines. You're building support around real life goals like morning independence, homework follow through, and cooperative behavior. And because Leo is in structured school settings, with staff who are willing to learn, you can design this model to amplify natural supports instead of replacing them with more clinical hours. This is where we step back and ask, what's already working here and how can we build on that? This is the essence of step 3, designing something that's not just effective, but sustainable, realistic, and respectful of the learner's day-to-day life. All right, one more. Let's look at what this looks like for Maya. Maya is a 6-year-old. She engages in frequent self-injury, headbanging, and biting others. She currently has no functional communication system in place. Her parents are caring and concerned, but they're overwhelmed and not consistently aligned on routines or expectations. Their stress level is high, and they've been hesitant to commit to past services. Her clear score was 13, which puts her in the high intensity range of 20 to 30 hours per week. This is a case where a higher number of direct hours is likely appropriate, not because it's the default, but because the level of clinical risk and the current skill deficits require a more intensive approach to stabilize safety and build a foundation. So that might look like 30 hours of direct RBT services per week, with 3 to 5 hours of supervision at the beginning and 1 hour of parent training, not focused on fluency yet, but on building trust, small wins, and emotional safety. Even though the number of hours is high, this plan is still least intrusive for this specific context. And we're doing so with the intent to fade as stability increases and parent engagement builds. For Maya, a low intensity model would likely fall short and could even put her and her family at risk. But our ethical obligation is the same. Only recommend what's necessary, deliver it with fidelity, and keep working toward a point where less becomes possible. Recommending the least intrusive intervention is so important because it also opens the door for us to improve access to services for all families. Every time we approve a high intensity treatment model, especially one that may not be truly necessary, we're using more than just hours. We're using clinical resources, staff capacity, and in some systems, we're also using up part of the funding pool that supports all of the families. Now, that doesn't mean we shouldn't recommend high intensity services when they're clearly needed. We absolutely should. But it's worth asking what happens when we apply the same model, 30 plus hours, a single RBT at high intensity to every child who comes in the door, even if a lower intensity or even a parent training model could provide similar results. So here's what happens. Fewer families can get services. The wait lists grow longer. Families who could have benefited from low intensity services wait months or even years for a chance at care. Equity isn't about offering everyone the same thing. It's about making sure every learner gets the right thing for them. And that starts with us being intentional about dosage, not just for this case, but for the overall sustainability of care in our communities. When we start low, scale as needed, and leverage family capacity, we're not reducing quality, we're increasing access. And that's an ethical commitment as well. So step 4 comes in after services already start. It's where you make adjustments based on treatment fidelity as well as program and other available data. You've made your initial recommendation based on the scorecard, your clinical judgment, and the family's context. But now it's time to look at what's actually happening. Is the plan being implemented consistently? Are you seeing progress? Are the supports being used the way you envisioned? This is where you pause and ask, are the hours effective? Are they sustainable? And are they actually helping this learner and family move toward their goals? And here's something we don't talk about enough. Fidelity issues don't always mean there are too few hours. Sometimes they're a red flag that we're doing too much. Let's say there's only one RBT on the case and they're working long days with the same client. Even the most committed staff will feel fatigue. Sessions drag, reinforcement schedules drift, programs get skipped or run half-heartedly. The same thing happens with kids. A 4-hour day of instruction might look good on the schedule, but if the learner is tuning out halfway, then we're not getting what we think we are getting, what we intended to get out of that day. This is why we need to assess not just whether services are happening, but whether they're being delivered well. So in this step, we look at 2 main things: the progress. We ask, is the learner moving toward meaningful goals? And fidelity. Are the interventions being implemented as designed? We need to consider the RBT consistency and coverage, session length and quality, caregiver follow through, and the learner engagement. If things aren't going well, we don't default to adding more hours. We ask, is this team stretched too thin? Are we giving enough support and training? Would fewer, more focused hours lead to better outcomes? This is what keeps dosage ethical, not just at the start of treatment, but throughout. It's not about sticking to our original plan. It's about adjusting when the data tells us to. So let's take a look at this with Cam. You had a solid treatment plan in place. Both parents were involved, parent training was happening, and the dosage was intentionally moderate. But when you reviewed progress data, you noticed slower skill acquisition than expected. When you looked closer, you found inconsistencies in how the RBT was delivering reinforcement, missing components of skill acquisition programs, and using less effective prompting strategies than you initially trained. It isn't a capacity issue with the staff or client. This is a training issue on the implementation side. The RBT is relatively new and hadn't received enough modeling or feedback. So in this situation, you don't change the hours. You increase supervision, provide targeted coaching, and spend time ensuring that the RBT can confidently and consistently implement the plan. Hopefully within a few weeks, you will begin to see some gains, not because you added more hours, but because you strengthened the treatment fidelity. All right, so let's look at Leo. Leo's case is a great reminder that when you design a plan around the learner and family context, it often just works. He had a clear score of 4, and you recommended a lower intensity model focused on social and daily living skills. His mother and grandmother were receptive to coaching, and the school team was actively supporting him during the day. You've been tracking Fidelity weekly, and the RBT is doing a fantastic job. You provide regular supervision, programs are being run correctly, and the learner is progressing steadily. There's no reason to change anything here. This step isn't about changing the plan every time. It's about confirming whether the plan is working. And in this case, it is. So you maintain the status quo until it's time to start titrating hours for discharge. Maya's case is a bit different. You had set up a moderate intensity program with a consistent RBT delivering most of the weekly hours in long sessions. In the first few hours of the sessions, Fidelity's typically strong. Interventions are implemented well. Progress is somewhat visible. But in the second half of each session, things seem to change. Maya is more resistant. The RBT seems fatigued. Programs aren't completed. Prompting and reinforcement aren't consistent, and engagement starts to drop off. So you have a choice. You can either shorten session lengths to keep Fidelity high or bring in a second RBT to split the hours and avoid burnout. You can also look at parent training. This family has some capacity and could shift part of your time to coaching and the caregiver to manage routines that are especially hard for Maya during those last hours of the session. The key here isn't to assume you need more hours, it's to refocus the hours you have to make them more effective. All right, so we're on the final step in the framework, but it's not just the last step in your planning process. It's a step you'll return to again and again, because this isn't just about your initial recommendation. You're going to revisit the decision at every reauthorization, every progress review, every time something shifts, whether the client is making big gains, not responding as expected, or the family situation changes. This is where everything you've gathered, the scorecard data, parent input, observations, and real-world constraints gets turned into a number and a written plan. And that can be tricky. You know what your client needs, but the system doesn't always make it easy to request that. Some insurance companies routinely flag anything over 25 hours for peer review. Others seem to deny increases no matter how much data you submit. So it's easy to fall into a mindset of what's most likely to get approved instead of what's most clinically appropriate. But that's not our role. You don't need to write for the system. You need to write for the client. This step is about advocating effectively by grounding your recommendation in actual clinical data, describing how families, learner, and environmental variables shaped your decision, and clearly stating how you'll monitor progress and make adjustments. Whether you're recommending 10 hours or 30, the goal is the same. Make the case for the most appropriate, sustainable plan for this learner and their family, no matter, not more and not less. That's how you stay ethical, protect access for others, and preserve the integrity of your clinical work. ABA isn't a cheap service. Depending on region and provider, hourly rates can range from $120 to $150 for just an hour of services. Multiply that by 20, 30, or even 40 hours a week, and you're looking at 6 figures per year. Yes, insurance companies foot most of that bill, but where do they get the money from? From us. From the premiums that we pay, from state-funded plans paid by our taxes. It's not magic money that comes out of the air. So recommending 30 or 40 hours per week doesn't just affect that one case. It impacts the sustainability of the services across the board. And when hours are inflated unnecessarily, it limits access for others. These are important truths to hold in mind as we think about what it means to recommend responsibly. So if the system tends to deny increases, It makes sense that you'd want to start high just in case. That's the default in many places. Recommend the highest number you can justify now and reduce later if it turns out that the learner doesn't need that much or the family can't meet those number of hours. On paper, that looks safe, but in practice, it's often wasteful, overwhelming, and inefficient. It uses up staff capacity, it burns out families, and it makes access harder for everyone else. It's the surgery before antibiotics model, just like the story about my cat. If we never even try the least intrusive model, we'll never see what it could do. So if you're not recommending the safest number, how do you make sure your recommendation holds up? The key is clarity. Your plan should clearly link the learner's strengths and needs, the environmental and caregiver supports that are available, and the number of service hours required to meet specific measurable goals. For example, if you find the need to increase hours, you might say something like, this client has shown emerging communication skills, but continues to require high prompting and support for generalization across all settings. Parent training sessions have demonstrated high fidelity, and the family is requesting additional support for behavior management during routines. Increasing direct service hours from 15 to 22 hours per week will allow for structured skill building across 2 additional routines, mealtimes, and transitions, which are currently associated with high rates of problem behavior and caregiver stress. So when the rationale is precise like that, it becomes much easier to justify the change in dosage. Whether you're recommending 10 or 30 hours, your job is the same. Make the clinical case for what's needed and nothing more. One final reminder as you make these decisions, families are not funding streams. They are partners in care. When we recommend more than is needed just because we're afraid, we shift our focus away from the learner and toward the system. But our code of ethics is clear. Services must be individualized, evidence-based, and least intrusive. That's what you're trained to do. That's what the families are counting on. And that's how we help this field be sustainable, not just for today, but for years to come. CAM began services at 20 direct hours per week with 1 hour of parent training based on clinical need, caregiver capacity, and environmental support. Over the past 6 months, after increasing the training for the RBT, CAM has demonstrated progress in structured teaching sessions, including increased independent responding and decreased latency across several targets. However, skill generalization across home routines, particularly transitions and toileting, remains low, with frequent tantrums and aggression noted when task demands are introduced outside of sessions. Parents have demonstrated high engagement and fidelity during coaching sessions, and additional parent training is requested to support generalization. You decide that the data indicate he would benefit from an increase in hours. Along with the information I just mentioned, you could include the following as justification in your plan. Due to the intensity of support needed across daily routines and the importance of consolidating gains into natural contexts, we are requesting an increase to 25 hours of direct service per week and 2 hours of parent training. These hours will allow focused intervention during routines where behavior is most disruptive and ensure continued caregiver collaboration in home-based strategies. Progress and fidelity will continue to be monitored weekly. All right, now let's take a look at Leo's example. Leo's current treatment model includes 18 direct hours and 1 hour of parent training per week. Nope. Leo's current treatment model includes 8 hours of direct work and 1 hour of parent training per week. This dosage is determined using the CLEAR framework and aligns with Leo's low clinical needs, supportive home environment, and increasing independence with core skills. Over the last 12 weeks, Leo has demonstrated consistent progress in social skills with reduced task refusal and improved self-help skills. Skill acquisition data shows a 70% mastery rate across targets introduced during this period. RBT implementation fidelity has remained above 90% across 3 consecutive monthly observations, and the family has reported satisfaction with Leo's engagement and gains. Kind of an ideal case, right? You decide that keeping his hours consistent is what's best for him and his family for the next authorization period. So in addition to the information I just mentioned, you add the following to his treatment plan. At this time, continuation of the current dosage is clinically appropriate to maintain momentum, support generalization, and avoid unnecessary disruption to a well-functioning model. Progress and fidelity will continue to be reviewed weekly to ensure responsiveness to Leo's evolving needs. When you are recommending a just right amount, it becomes very easy to justify the amount of services. All right, so let's take a look one more time at Maya. Maya began services at 30 hours per week due to high clinical need, including frequent self-injury, limited communication, and caregiver stress. You noted that the staff and Maya both experienced fatigue, reducing fidelity and progress. You reduced hours to 25 hours per week. That model was effective in addressing immediate concerns. In the last 6 months, you've observed a sustained decrease in problem behavior, increased use of functional communication, and strong fidelity in implementation. Parent training sessions have also resulted in significant gains. Caregivers are now able to manage transitions, use prompting strategies effectively, and implement a visual schedule with consistency. You decide that titrating hours would make the service more manageable for the family while sustaining her progress. So along with the information I mentioned, you add the following to her treatment plan. Given Maya's progress, caregiver involvement, and current trajectory, we are recommending a reduction to 20 direct hours per week. This titration maintains support for ongoing skill acquisition while allowing for a more sustainable, less intrusive schedule. The family will continue receiving 2 hours per week of parent training to support generalization and independence. Progress, fidelity, and caregiver implementation will be monitored weekly, and dosage will be reevaluated every 12 weeks or sooner based on data. Even when you use a structured process, you can clearly justify the number of hours you request. You often encounter pressure from all sides when you're writing a treatment plan. Maybe your organization has a policy that families must commit to 30 hours a week. Maybe the parent wants fewer hours than you think are needed, or more than you think are appropriate. Or maybe you've learned that sticking close to the industry standard makes getting a plan approved feel easier, even when it's not the best fit. And let's be honest, insurance companies rarely push you to increase hours. If anything, they scrutinize anything that falls outside of the box. That can make it tempting to just play it safe. But here's the truth. You don't have to take an oppositional stance. You can advocate with calm clarity, not defensiveness. Try saying something like, I used a structured scoring tool to guide this recommendation. It reflects the learner's current needs and the family's capacity to support those goals. And that's a good argument for your supervisors if they're pressuring you to request more hours. And for families who want fewer hours, you can say something like, I hear that this feels like a lot. We can talk about what this would look like in practice and revisit the dosage as we monitor progress. You're not here to sell a specific number. You're here to make sure the services match the actual need, nothing more and nothing less. When you can speak from a place of thoughtfulness and structure, it's much easier to stand behind your decisions, even when others don't immediately agree. When we think about dosage, we often focus on one child, one family, and that's where it should start. But your clinical recommendation doesn't exist in a vacuum. It has ripple effects across the system. First, let's talk about burnout. When we default to high intensity models, especially in home settings, it stretches staff thin. We're asking RBTs to deliver 30 plus hours a week, often as the only RBT on a case. They get tired and fidelity drops. And over time, so does retention. Smarter, more thoughtful dosage leads to more sustainable workloads for everyone. Second, access. When one client is receiving more hours than they need, those are hours another child may be waiting for. Least intrusive plans allow more families to start services sooner, reducing wait lists and improving equity across the system. And third, real world fit. We don't practice in ideal labs with unlimited staffing and highly controlled variables. We practice in the real world where it's often messy, with parent work schedules, staff limitations, funding constraints. Smarter dosage decisions recognize those realities and build models that can actually be delivered with integrity. Ultimately, this isn't about doing less. It's about doing what's effective, sustainable, and ethical for our clients so that we can keep doing this work in the long term. There are a few myths that I hope you are all ready to leave behind. The first one is that more hours always leads to better outcomes. We now have multiple meta-analyses, including the Sandbank et al. 2024 analysis showing that higher hours aren't consistently linked to better outcomes, especially when you account for how services are delivered and who's involved. Quality, fit, and fidelity matter far more than raw intensity. The second myth I hope you're ready to abandon is 30 to 40 hours is the gold standard. That idea came from a very specific study under highly controlled conditions. What we deliver now, often naturalistic, play-based, home-based services, isn't the same model. And what a 2-year-old needs may look very different from what a 12-year-old needs. We can let go of the one-size-fits-all method of dosage for ABA services. All right, and the third myth is that parent training must follow direct services. Many providers think of parent training as something that you add on after direct service plan is in place, but that's not the only way. Parent training can be a primary model of service delivery, especially when family capacity is high and the child's needs can be addressed through caregiver-led implementation. It's billable, it's effective, and it often leads to stronger generalization and long-term outcomes. As BCBAs, we need to update our models to reflect what's true now, not what was true decades ago. We don't have to keep practicing under outdated assumptions. We have better tools, better data, and better frameworks. And that's what allows us to serve our clients better, not just more. As we close, I want to leave you with this. Making ethical, individualized, and sustainable dosage decisions isn't easy. It takes more than knowing the research. It takes balancing science, systems, and human lives. And in a field where recommending more is often seen as safer, it can feel risky to go against the grain. But ethical doesn't mean excessive. Advocating doesn't mean inflating. It means getting clear about what the learner needs, why they need it, and how you'll deliver it with fidelity and flexibility. You don't need to convince an insurance company to approve the biggest number. You need to justify the right number for that individual client. And that number might start smaller. It might include more parent training, and it might evolve over time. But it's built from real data, from real context, and from real collaboration. Then that's valid and it's worth advocating for. You have the tools now, you have examples, you have a framework. Start small, justify well, adjust the purpose, and that's what clinical integrity looks like. And that wraps it up for today. I hope you all walk away with the tools you need to implement the strategies I brought today. If you're watching this for CEUs, you need to complete the quiz for this lesson. After you pass the quiz, you're going to receive a link to a brief survey. please take a minute to complete it and let me know what you thought of this course. It helps me improve the courses that I'm offering. If you've been taking the courses from me for a while now, you've probably seen an improvement in the courses, and that's based on the feedback that I've been getting from people. Make sure to email me with any questions or comments that you have at support@masteraba.com. Thanks for joining me today, and I will see you all in the comments.